I'm Dr. Malhi. I'm a child psychiatrist and I work at Krishna Care and also consultant for DCPAP. So I will be presenting on depression in children and adolescents today. So some of the information that I'll be sharing, I'll be um, speaking a bit about them, but most of the information will be on slides so that you will have an opportunity to review them if you want to go further into details. So during this hour, we'll identify symptoms of depression in children and adolescents using evidence-based tools, and also talking about some evidence-based modalities while we manage the side effects, and also thinking about what are the future therapies that are coming, that including some novel and integrative approaches. So, as you already know, depression is very common psychiatric disorder in children and adolescents. It used to be believed that it's not as commonly present, but if you look at lifetime and past prevalence of MDD, around 11% and 7.5%, and more prevalent in females. And there, it is a one disorder that is associated with the suicidality, and 10% of those patients have also reported suicide attempt. Certainly a bit lower in children compared to adolescent population. In children, it's like around 2%. These are the DSM-5 criteria. The patient has to meet either a low mood or depressed mood or decrease in interest in enjoyable activities. So one of these need to be met along with 4 of any of the below symptoms. Either it could be sleep changes or interest, feeling guilt, worthless, hopeless, energy changes, concentration, appetite, psychomotor agitation or retardation, and then suicidal thoughts or recurrent thoughts of death. So any 4 of those present along with one symptom of mood or anhedonia, any one of them could be present, that patient will meet the criteria for MDD episode at the time of evaluation. And then, as you know, that children may present slightly different from adults when they are experiencing some of these symptoms of depression or a full episode of depression. In preschoolers, you may see more irritability, temper tantrums, low frustration tolerance, absence of joyful play. In school-age children, we see more like somatic complaints or more agitation, irritability, and some of them can have like hallucinations, auditory hallucinations as well. And then in teenager is where there is more anhedonia, like decreased interest in activity or maybe more suicidal ideations. And sometimes it can present atypically also, that where we may see the teen is sleeping more, or they have a lot of appetite, or they are more like slow all the time, and really very, very sensitive to any type of interpersonal conflict. So those are the symptoms that can be present when you are assessing children for depression. And these are some different types of depression. Psychotic depression is when depression is so severe that the child may experience some kind of hallucinations, auditory, visual, or paranoia. And usually in those cases, I always pay attention to if there is a positive family history of bipolar disorder, or how long the depression episode have been present, and have there been any treatments that the patient has tried in the past. And atypical depression, I already talked about, where there is a more sleeping, more appetite, and more like slowness in the body, and then more sensitivity to reaction. And seasonal affective is where there is changes in the mood with season, especially with the decreased sunlight. And then persistent depressive disorder is also very, very commonly seen, in cases where there is a mild symptoms of depression, but they are present all the time. And they're present enough that they can cause impairment in day-to-day life. So if you go by MDD DSM-5 criteria, patient may not meet the full MDD episode criteria, but they still may have symptoms that require attention, and those may qualify for the persistent depressive disorder. And when you think about the etiology of the depression, there are various causes. Either could be some genetic. We have known that if there is a heritability, family members may have mood symptom present, and that put the children also at a higher risk. Any comorbid conditions present, such as anxiety, ADHD, those also put people at higher risk for depression. And then there are psychological causes also, like history of trauma. I always pay attention to that. Or there is a authoritarian type or versus authoritative type of where there is more coercive, like parenting styles. That can be one of the risk factors for development of the depression. And then inborn, like inherent, like also temperament of the child while growing up that put them at a higher risk for conflict with the parents that lead to more psychological causes for development of depression. And then there are social factors also that can cause depression symptoms, such as like what's happening in the school, like if there is ongoing bullying, trauma, or stress with the school, peer pressure. And then also keep in mind that sometimes, like in social factors, also include what is happening at home. Is the parent struggling themselves with a depression episode that can put the child also at a higher risk for depression symptoms? One of the major STAR-D trials, which is one of the landmark studies in adults for depression, they also further ad hoc analysis reported that if the children, the mothers whose symptoms improve by doing the treatment of depression, their children's also improved in the mood symptoms once the parent got better. So really important to keep in mind all these other factors that could be the etiology that can cause contribute to the etiology of depression. So once we have known the etiology of the depression, now we're thinking about, okay, the patient is in the office. What are we going to do about it? Definitely collateral information from the parent is very important. I also try to gain information from the school, how the academic functioning of the child is in the school. And if the child has a therapist, that can also give a little bit more insight into it, like what's happening. And I do use some objective scales also to get us some objective assessment for the depression, such as PHQ-9 for adolescents is the common scale that we utilize in our clinic, but there are some other scales also, as mentioned here, that can be utilized. And some of them are public domain. Some of them could require like buying the scales as well. And what to look for in clinical assessment of depression, as we talked about all the risk factors, such as any trauma history or any comorbid symptoms of anxiety, ADHD, all put them at a higher risk for development of depression. And then any psychotic symptoms need to be ruled out. And symptoms of mania are really important because you may be seeing the patient when the patient is presenting with depression, but they may have experienced some symptoms of mania or hypomania as well in the past. So really ruling out that there is no bipolar with the patient is important, is critical when you make the treatment plan for that patient, because the treatment plan can very much differ if the patient is presenting with unipolar depression versus if the patient is presenting with depression, which is the part of the bipolar disorder. And then if there is a family history of suicide and past suicide attempts by patient or self-injurious behaviors by patient, really important to consider safety as a primary concern for the parent and for us as well, to make sure that if outpatient level of care is going to be okay, or should we be referring the patient for the higher level of care. So other differentials to consider when you're doing the assessment is the medical conditions. I think pediatricians, all of you guys do a really good job in ruling out any of the other disorders that could be contributing to the mood. One of the things that we always keep in mind is hypothyroidism, that symptoms can lead to a lot of tiredness also, and can also be comorbid with depression. And also vitamin D deficiency is commonly seen. Patient can look like depressed when they're excessively tired for very low vitamin D. So that can help taking care of the symptoms and can clear the picture once the vitamin D is taken care of. And then other neurological disorder, epilepsy, migraines, all those can also be very much a risk factor for development of depression symptoms, or could be comorbid with depression as well. So really treating those conditions first and then doing the evaluation. If the symptom persists, then we can do the treatment for depression. If they get taken care of, then possibly no treatment will be required at that time. And then other than that, we also do some physical exam and then ruling out any other positive physical findings, or even the lab test, including vitamin D, B12, or any urine drug screen or other lab tests to be considered based on the patient history. So some of the common labs based on the presentation can be considered when you're evaluating the patient for the visit for depression. So when you look at the patient, what are the things objectively you will see in the patient, like in addition to some of the collateral information that you take from the patient is certainly poor eye contact, not much engaged in the visit, like not taking care of their hygiene, and then even irritability or slowness very much witnessed in the office. And when you ask a question, very limited responses like poverty of speech, which is not like their usual self, and really not like understanding what's going on and not forthcoming to take the help, which we commonly see in many teenagers. Like parents will tell that they're spending a lot of time in their room, don't want to come out, and refuses to go to school, don't do the work either. So some of those things could be considered, and some of them can be witnessed in the office as well when you're doing the evaluation. So when you think about depression, it has episodic nature. If you don't treat the depression symptoms, usually it's a self-curing. 8 to 9 months, one depression episode will get better by itself. But in some cases, it can become chronic also if we don't treat them. And chronicity could be like if there is underlying trauma and substance use, anxiety, or personality changes, personality disorder, like or temperament problems. Those are the patients who are at higher risk for developing chronic depression. And the persistent depressive disorder can last for over 3 to 4 years as well, which can really affect the quality of the life for these children and teenagers that we take care of. And if you think about the recurrence rate is very, very high. Even if you have treated the patient, it's really important to keep in mind that if you have treated it one time, it's quite possible that up to 20 to 60% of the patients will relapse in 1 to 2 years. And up to 70% of the patients you have treated for depression will relapse and have another episode in 5 years. And prepubertal depression also increases risk for bipolar disorder. And also other risk factors for bipolar are like any drug inducer. You start an SSRI and patients start having mania, hypomania. Something I always keep in mind that is this patient at a risk for bipolar or psychotic features, or patient having hypersomnia or positive family history of bipolar disorder. So those are the things I keep in mind when we are continuously evaluating the patient with the depression, first episode of depression, and then consistently taking care of the patient over a period of time. So I usually do bipolar evaluation in every visit because you never know if someone has been diagnosed with depression at age of 12 or 13, at 14 or 15, they may have an episode of hypomania. So really getting to know them every visit, if they experienced any bipolar symptom, not just in the first visit, would be important because developmentally over the course of period, if someone is at risk for bipolar disorder, you'll around 15 and above, like you'll start seeing some symptoms of bipolar as well. So that can kind of impact your treatment plan in those cases. So coming down to the treatment modalities, I certainly education is very important for the parents to stay engaged and to also give them some hope that we can treat these symptoms, but it will require consistency in their treatment plan. Supportive management is active listening, offering the hope, problem solving, coping skills, providing the support all what they need, either with the school or with giving them resources or in any cases with like safety assessment, things like that. And also need to consider that some of these families can be very rigid about starting treatment plans, especially the medication. So I try to give my recommendations, but there are times when you have to amend the treatment plan based on what is family ready at that time and continue to keep working with them and with the school to provide the much possible care to the child. So usually as you think about the treatment plan, if the symptoms are mild or moderate, you can start with the psychotherapy. Some of the psychotherapies that have evidence-based for depression are interpersonal, CBT, and if they don't work and the patient wants to try medication, I'll show you some data on using either therapy or medication, which intervention works best, or which you should be considering. So in those other cases, medications can be considered. So goals of the treatment are like response. One is a reduction in the symptoms, like even up to 25 to 30% reduction in the symptoms for 2 weeks. With the response, that would be the partial response. What we say response is at least 50% reduction in the symptoms in 2 weeks. Then we say that, okay, medicine is working. And remission is that when the patient more than 2 weeks, but less than 2 months with no symptoms or very few symptoms. And what we call recovery, which is our goal, is continuous absence of symptoms for more than 2 months, where the patient will come over a period of time and they say that they have not had any symptoms of depression. That's where we want the patient to be. So pathway to treat is certainly after evaluation, establishing the diagnosis. If there are mild symptoms, start with the therapy. If there are moderate symptoms, you can start with therapy, but if the family is willing for medications, you can start medications also, or both of them can be started. And for severe symptoms, psychotherapy plus medication is recommended. And how do I categorize what is mild, what is moderate, what is severe? Usually try to go by the PHQ-9. If it's up to between 5 to 9, I say it's mild. 9 to somewhere between 14 to 15, that's like moderate. Then 15 to 19 is severe, moderately severe. Anything 19 and above on the PHQ-9 for adolescent version, that I consider as a severe symptoms, where I also do very thorough safety risk assessment and also give them the option to do the treatment with medications and therapy. So if you go by medications, which it seems like are going to be most of our like rest of the presentation will focus on, SSRIs as the highest response rate. But you also have to keep in mind that placebo also has a very high response rate in children. So, but that doesn't mean that we won't start the SSRI. Yes, we definitely start the medications, but certainly some of the things that we do in a therapeutic alliance in the office are listening to the patient, giving them hope, providing that therapeutic support to them also has a significant positive impact in taking care of the symptoms. So always keep that placebo response in your mind, even when you're doing SSRIs. And the number needed to treat in children and adolescent is 10, which basically means that you treat 10 patients and then one of them would get better. So it's not like same as antibiotics, but still good enough that we certainly need to consider. And if you use these SSRIs for anxiety, the number needed to treat in those cases is close to 3. So really work very well for anxiety symptoms, but not as much as good as for depression, but certainly still can benefit the patient to huge amount, considering the severity of the symptoms and how does it impact the quality of their life. In regard to FDA approvals, we have fluoxetine has FDA approval for treating depression in children and adolescents, and escitalopram, which is Lexapro, also has an FDA approval. Usually, once the patient has responded to the treatment, doing well, I continue the maintenance treatment for a minimum 1 year. But then if someone wants to extend to even 2 years, that's totally acceptable as well. But in at least minimum 1 year with the first episode, continue the maintenance treatment with the depression so you can prevent the risk of relapse. As we talked before, the risk of relapse in these patients is up to 20 to 60% in first 2 years and up to 70% in 5 years. So really need to make sure that you continue that maintenance treatment in such patient. And relapse rate is very high if the patient is not continuing the medications within the 4 months of their symptom improvement. They will relapse very quickly in those cases. So these are some of the studies we have known. Fluoxetine showed positive benefit. 60% patient responded to fluoxetine compared to 30% also responded to placebo. Then another study was done in 2002, which also showed 41% responded to fluoxetine and 20% also responded to placebo. Both the studies were like 6 to 8 weeks long studies and really helped us understand that SSRIs do have a benefit with helping our patients with the depression. And this is another study which we have known, TAD study, which is treatment of adolescent depression study, where they gave like there were 4 arms. One arm, they gave SSRI plus CBT, which is therapy. In second arm, they gave only SSRI. And third arm, they only gave psychotherapy. And the fourth arm, they gave the placebo. If you look at the number, 70% of the patient responded to combined treatment. So if you want to have a best outcome with treating your patients with depression, suggestion is that you start the psychotherapy, you start the medications, but then sometimes there could be limitations with availability as well, especially in a low resource state like Delaware, where you may not have as many opportunities to do evidence-based treatment. So definitely medications can be considered. And if you see the response between SSRI plus therapy and only SSRI, which is fluoxetine alone, still quite a good comparable response. Like 70% patient responded to SSRI plus CBT, and 60% patients also responded very well, even if they were only given SSRI. And if you only give therapy, 40% of the patients still responded. So really need to think about that all the treatment interventions do work, but some work more effectively than others. But then that's where our individualized tailored treatment plans play a role, what the family is willing to and what they have tried and where they stand at this point. And then there is benefit with the suicidal ideations as well when in this particular trial when the patients were responding to their symptoms. And then additional study that also shows that if someone has already tried one SSRI and they didn't respond to that, what should I do? Should I switch to another SSRI, such as someone has done fluoxetine? Now the fluoxetine did not work for them. Patient is still struggling. Should I switch to maybe Lexapro, or should I go to another medicine such as Venlafaxine and Cymbalta, which is a different class of medication, which is called SNRI, selective norepinephrine reuptake inhibitor. In this particular study, they help us to guide what to do next when we have a poor response to first medication. Idea is that there was no difference even if you switch from same class or you switch the different class. And what made it better was basically adding the therapy. So really thinking about that if you have a patient who hasn't responded to one medication, are they in therapy or not? And even if you're changing the medication to another medication, do get them into therapy with the resources available so you can have a better response. And these are some of the studies that I want to show you on the right hand side. It shows the grades, like grade 1A, which has the best efficacy, and the grade 2A would be where we have a moderate evidence. And then some of the medications we already know, fluoxetine, escitalopram, which are FDA approved, also have a grade A recommendation, and sertraline, which also do not have FDA approval, but also showed positive benefits for treating depression and can be considered in your practice as well, also has a grade A recommendation. And then there are some negative trials also, which has not shown same level of positive benefits when treatments are given. But that does that mean that we do not utilize them? Some of the medications we do not utilize as often in pediatric patients, such as paroxetine, Paxil, have a lot of side effects, short half-life. So that medication is not utilized much in pediatric patients. But as citalopram, we know that even if there is a negative study, failed study, it has an FDA approval. And then escitalopram, which is also kind of sister medicine of Lexapro, I have utilized that medicine. Yes, it's not grade A, but it's given grade B, that we have some evidence that can be beneficial. And same thing with other medications such as Venlafaxine, which is SNRI, and Mirtazapine, which we commonly utilize as like a third line option when SSRIs and SNRIs have failed. And these are some of the other medications. You have known Luvox has shown some positive benefit, not really first line indication, but certainly come at as usually a third or fourth option. Same thing with the Cymbalta, also did not show overly positive results, but it's FDA approved for anxiety in children, so can be utilized only once our initial options have failed. And then some of the newer medications like Vibrate, vortioxetine, results have been very mixed so far, and we don't have like quite enough good data to say that these are the medications that are going to work for our pediatric population. So I only consider them if we have reached a point where none of the other options that are 1A, B, or C have not worked, then these can be considered in those circumstances. And we'll talk about bupropion in a little bit. And this is some of the other medications such as atomoxetine that has not have like even atomoxetine is a Strattera, it's ADHD medication. It is SNRI, hasn't shown much benefit with the depression symptoms. Levomeldacipram, that is same. It is not like as it is not present in the US market, but certainly present in the European market, has not shown as equal benefit with with the depression trials. And we said we are not very commonly utilizing TCAs. It's not a one of the common drug, nortriptyline or selegiline, MAO inhibitors, not commonly utilized in pediatric population. And some of the trials have also shown negative outcomes for these medications. And ketamine, we know that esketamine is being studied, and then IV ketamine as well. Some of the results are coming out, but they have not been FDA approved. And then there is also a new trial that is pending at this point is saltroxone. That is orexin 2 inhibitor, but that is also commonly that being studied in adults, not so much in children at this point. So these are some of the like novel medications that some of them are being utilized in adult population, but not so much often in pediatric population. But really need to know that these are the medications on the shelf and are being considered that if they would be an option for pediatric patients or not. Bupropion, also known as Wellbutrin, I'm pretty sure that many of you are already aware of this medication. It's a medication that is commonly utilized in adult population as an augmenting agent for depression and also for ADHD. And in pediatric population, if in my own clinical, it's not FDA approved for use in children, but if I ever have to utilize it, it is possibly only in teenager patients, especially older teenagers, where there is a lot of like amotivation, where with the depression symptoms, where this can help with some of its dopamine effects to help take care of that depression and poor motivation. So in those cases, I have utilized it. You really need to be aware of treating, not utilizing if someone has a comorbid like eating disorder or seizure history or TBIs. Those are the cases where Wellbutrin may not be the right choice to consider. And also sometimes if there is a sub-syndromal symptoms of ADHD, like patient does not meet the full criteria for ADHD, but have some symptoms that struggling with the focus and along with some mood symptoms as well. In those cases, it can be considered in adolescent patients as well. I have hardly utilized this medication in pediatric, like a younger population, but if I have utilized this primarily in the teenager patients. And these are some of the names of antidepressants. I thought that would be good for you to know. Celexa, which is citalopram, 10 to 40 milligram. Lexapro is 10 to 20 milligram. Fluoxetine, which is Prozac, you can go up to 60 milligram. Fluoxamine, which is Luvox, another SSRI, can go from 50 to 200 milligram. Paxil is 100 to 50, not commonly utilized, but can be considered if absolutely needed. And sertraline Zoloft is 50 to 200 milligram. How do you start these medications? I always tell the families that we'll start with the low dose, see how it goes, and then make the adjustment according to it. I try to tell them stick with the same schedule. If you pick morning, do the morning. If you pick evening, pick evening. And if you pick morning, some of the these medications can cause tiredness, so watch for sedation. And then in the younger population, it could be possible you may have to do BID dose. And usually a goal is for the remission. Try to give like adequate trial every 3 to 4 weeks. You change the dose. And I usually give like 10 to 12 weeks for one medication before I think that this medication is not going to be working and we have to try another medication. And after patient has been in remission, like in the recovery, symptoms are going well, at least maintain the treatment for 1 year. And GI side effects are some of the common side effects with these medications. Or what you can do in those cases, I tell the parents to take the medication with the food. And if it causes headaches, usually gets better, they can use Tylenol. That's a common side effect as well. If some of these medications can cause impulsivity, activation, like really not bipolar type, but just more like energetic, hyper, not themselves. And that really doesn't go away. In those cases, I may have to reduce the dose or may have to consider another medication. If it causes insomnia, if the patient is taking in the evening, I can switch it to morning. And if it causes sedation, then you can kind of switch it to the evening. That can help with the sleep as well. In teenager patients, keep in mind with the libido also, like sexual side effects can be possible that can lead to non-compliance. Many times teenagers may not tell you. It's always good to ask them. Like I usually give them some privacy from the parents so they can talk about these symptoms. And also at every visit, talking about symptoms like hypomania to assess for underlying bipolar. And then thinking about withdrawal symptoms, like really educating them. If you stop the medicine, how can the blood levels can go down and you can experience withdrawals. And thinking about serotonin syndrome, if they take it with some of the other medications, such as it can occur as flushing, diarrhea, autonomic instability, delirious state, need to take them to the hospital, especially if they utilize any other serotonergic agents that can create a high serotonin neurotransmitter in the body. And then also drug-drug interactions, like if any of the other medications you are prescribing them can inhibit the cytochrome P450 in any ways, increasing or reducing the dose of SSRIs. Suicidal thoughts. That was one of the concerns always, like, okay, does these medications cause suicidal ideations? FDA even given the FDA warning in 2004, which was later revised in 2007, because once they gave the warning in 2004, that led to a sudden increase in more suicidal ideations because medications were not being prescribed in that fear. But then they revised it that usually whoever is being treated with these medications need to be observed closely, especially during the initial few weeks or initial months of the treatment. But overall, studies have shown that our patients get better and their suicidal ideations get better once their depression gets better. And comparative between suicidal ideations for patients who are taking the medication versus who are taking the placebo is very minimal. 4% versus 2% suicidal ideations were even seen who were taking placebo. So really need to think through that, educate the parents, prescribe the medications, have them give the call if suicidal ideations emerges. But beyond that, I think I still continue the plan as we discussed so that their depression can be taken care of. And this is one of the epidemiological study also to give you a little bit more perspective. They followed the patients, close to 500,000 patients when they first started SSRIs, and then now they've measured the outcomes after the inpatient hospitalization, measured the outcome over a period of time. And what they saw that suicidal behavior highest risk was like in 30 days prior to starting the medications. And once the medications were started, those behaviors became there was a reduced risk. And overall, there was no evidence between SSRI, no evidence that SSRIs overall increase the risk for suicidal ideations or behaviors. So important to know these things because that you can confidently explain that to your patients and their parents so that they can stay more compliant with the treatment. And other treatments, such as like if psychotic depression, where antipsychotics such as Abilify, risperidone, those things may be needed. If it's a seasonal affective disorder, like therapy may be beneficial. If you think that depression is part of the bipolar, and then mood stabilizer need to be considered in those. And then also thinking about if there is a comorbid eating disorder, anxiety disorder, substance use, ADHD, all those things need to be considered when you are treating depression because they are all risk factors and also play a role in making the symptoms worse. So monitoring, we do like in our clinic, we do regular monthly appointments to make sure that we track the symptoms over a period of time and make the adjustment in the medications based on the response. And withdrawal symptoms are really important. Some of the medication, these SSRIs have a lower half-life that increase the risk for withdrawal symptoms such as venlafaxine. So I try to use it, make sure that the patients take the medication every day. And the patients that are very prone and like, I feel like they're not going to take the medication every day, I tend to utilize medications with a higher half-life such as fluoxetine and also collaborate with the parents who making sure that they take the medication medication on a regular basis. And these withdrawal symptoms can come if you abruptly stop the medication, they miss the dose, and if there is a large dose reduction, like suppose you were giving 200 milligram, and suddenly so you say that, okay, reduce the dose to 50 milligram, that can also cause withdrawal symptoms. So really important to consider those things in mind, especially the withdrawal when you're managing the symptoms. And then how to differentiate withdrawal versus relapse. Withdrawal occurs immediately when you make any changes in medicine. It's very time limited. You go back on the same dose, symptoms go back, and symptoms can be restlessness, irritability, headache, dizziness. And response is basically it can resolve on its own, or if you have missed the dose, patient can take the dose and that can help. But relapse usually occurs when the patient has stopped the medication, can take weeks or months, and it's more like a symptoms of the psychiatric disorder itself, like the patient will meet criteria for MDD. And then for treatment of relapse symptoms, you will probably have to start the whole treatment plan from the scratch again and monitor the response. And it can take again 2 to 4 weeks to see the response, and then remission can take longer. And discontinuation, when you think about, okay, I need to take or taper off this medicine because I'm planning to start another medicine, that is also a very thoughtful approach. Usually I consider low stress periods could be the better time, such as summer, to taper and start new medication. But if needed to be done, there is something called hyperbolic tapering, that reducing the fixed dose at regular interval. We don't have much data for this hyperbolic approach in children, but there is a lot of literature in adults, but it can be easily, if you apply the same concepts, it produces a smooth linear decline in serotonin transporter inhibition. That way the risk of withdrawal symptoms go down. So pediatric would be if someone is on sertraline 200, you would continue to reduce that. Okay, you can go from 200 to 100 and then fix dose, and then reduce another 50%, then I reduce another 50%. In children, we try to do it a bit slowly. Like I would go at least for 3 to 4 weeks on one dose, and then another 3 to 4 weeks. So usually can take 2 to 3 months to take off, but I do start the other medication also at a low dose. So by the time this medication is coming down, I may have another medication already in place that I can go up. And so when you do plan this discontinuation and taper, do look it up of what is the half-life of both the drugs. If the half-life is long, then you can do even you can go a little bit faster. But if the half-life is very short, then you have to be mindful that it can cause withdrawals if you go too quick. And then if the patient has history of relapse or withdrawal symptoms in the past, and what's the severity of the symptom, if does the patient have any other support such as psychotherapy, and also monitoring once a medication is taken off, monitoring the response rate in the first 3 months. And if the patients are not responding, I always think about it. Is my diagnosis okay? Is my diagnosis right? Is the patient taking the medicine? Is the dose sufficient at this point? And do I need to switch to another class because this class may not be? If the patient has some response, like partial response, do I then need to add another medicine because this medication did help, but not to complete help? And then also history of trauma where psychotherapies could be very beneficial. And then some of the newer treatments such as IV ketamine, those are there are very few trials that are being done now. So I think those are some in the pipeline that we need to keep an eye on. But at this point, they are not FDA recommended. And then similarly, ECT, there are different different state laws for ECT, how the children can get pediatric patients can get ECT. In Delaware, you require assessment by 2 independent child psychiatrists before ECT can be considered in some of these patients. So these are some of the diagnoses and number of studies we have done where there has been some response in pediatric patients for ECT, but certainly not the first-line treatment. And we know that TMS has been FDA approved for 14 and above for adolescent depression, and and then there is also more ongoing as the TMS is developing in its modulation in its therapy, how these theta burst stimulations are delivered. There is something called intermittent theta burst stimulation, where the patient doesn't have to come like for 6 weeks every day, but this was done more so like where you can give like a lot burst stimulation in one session, and you have to come only for like lesser number of days. But that this study in children that was done did not show much positive benefit. But there is a lot needs to be done in this field with emerging treatments that we are utilizing in adult population, and looking forward to their utilization in pediatric population in the near future. So these are some of the facts that ACAP has on their website. You can certainly look into them. A lot of resources, and these are some of my references.